Hello everyone, and thank you for joining in to the Pediatric Pharmacy Association Core Competencies. This presentation will be on pediatric osteomyelitis and septic arthritis. My name is Jeremy Stultz, and I'm Associate Professor at the University of Tennessee Health Science Center, College of Pharmacy, and at Le Barnard Children's Hospital. I am an antimicrobial stewardship pharmacist on the team. From the disclosure standpoint, I do have some research funding, but none of it is really related to this topic. The objectives that I have for osteomyelitis and septic arthritis are to categorize different types of these infections, and then also evaluate empiric and definitive treatment options for both of them, and to recommend appropriate dosing and safety monitoring for first, second, and third line antibiotics used for osteomyelitis and septic arthritis, and finally to assess for patient improvement and possible switch from IV to oral antibiotic administration. In terms of guidelines, the most relevant guidelines to be aware of are the Pediatric Hematogenous Osteomyelitis Guidelines, which are published in 2021, and the vancomycin guidelines, which were published in 2020, because as you'll see later on, a lot of these patients do end up getting vancomycin. To make sure we're all on the same page in terms of general terminology and pathophysiology, in general, osteomyelitis, inflammation in the bone and marrow. Septic arthritis, inflammation in some sort of joint space. The most common sites of osteomyelitis itself is commonly in the long bones in children. Some examples: femur, tibia, and humerus. And about 5% sometimes may involve multiple bones. Septic arthritis can happen in most joints in the body. Commonly are in the knees, ankles, toes, or hands. And importantly, these can happen in combination, so you can have a septic arthritis also with some osteo involvement, or vice versa. And you can have abscesses that form at any of the above locations in patients with septic arthritis and or osteomyelitis. One of the big ways I try and teach students and residents about osteomyelitis and septic arthritis is related to its source and its pathogenesis. So generally, to get into the bone for osteomyelitis, bacteria enter and proliferate in the cellular and extracellular space, or extracellular matrix of the bone, and this is likely through the metaphysis of the bone due to high vascular supply in that area. And a joint, typically bacteria get into the joint space. So generally this occurs via either what is called hematogenous or contiguous. I put inoculation in the same area as contiguous because it is kind of, again, going from the outside in, but contiguous means there is an infection that brought it in, whereas an inoculation may be sort of a direct trauma. But the hematogenous, generally blood to bone. Sometimes there can be traumas associated with this. I've heard, they rolled their ankle or they landed funny on their knee, nothing really broke the skin, and then they end up having osteo. The thought is that is some sort of hematogenous spread from the blood to the bone. And that can be in a patient that is actively symptomatic and bacteremic, or potentially not symptomatic but have bacteria in their body, is the concept behind it. And importantly, on presentation, about 47% of hematogenous osteomyelitis, as they're categorized, have bacteremia on presentation. So again, that's why it can be asymptomatic of sorts on presentation or symptomatic on presentation. Then contiguous, this is generally the way I think of it, is through the skin to the bone. Could be a cellulitis that spreads down, or other skin structure infections that spread down to the bone, or it can also be a trauma that punctures the skin and gets all the way to the bone. And as we'll go into later, these can have some unique considerations if it is a trauma-related cause. Now, in the guidelines, they also break patients down based on complication or how sort of severe the infection is. One important thing to know is one definition that is out there is differentiating acute versus chronic. So acute means that the patient was diagnosed less than 4 weeks after signs and symptoms and they hadn't had a prior infection. Chronic, they've had the infection for more than 4 weeks, bone necrosis is there, and there may be relapse from a prior successful treatment. So just so you know, whenever you see a patient, you can do it based on severity and also is it acute or chronic. In the guidelines, they do go over uncomplicated and complicated. Uncomplicated, typically single bone. They respond pretty quickly to some of the treatments you give them, even though they may present like really sick at the beginning, but if they bounce back in 1 or 2 days, that can still be uncomplicated. There's no real abscess, or if there is an abscess, they got rid of it with one sort of surgical procedure. They don't have to have repeated surgical procedures. If they had bacteremia, it resolved pretty quickly. You may only have it on the first blood culture. There wasn't really any sort of acute sequelae associated with the infection, and there's no concerns for late sequelae or long-term complications. Now, complicated on the flip side of this, more than 2 bones, slow response. They may need multiple surgeries and have issues with source control. Bacteremia for numerous days, 3 days or more is kind of their cutoff. Some of the sequelae that these patients could have, venous thrombosis, septic thrombophlebitis, endocarditis, etc. And there are concerns for injury impacting bone growth or some sort of pathologic fracture, making it, again, more complicated. So this is some of the complicated versus uncomplicated that's in the guidelines to differentiate between types of osteo or septic arthritis in patients who present. Some relevant epidemiology, just so you know how often it is in the general population. It ranges anywhere from 1 to 13 or so cases per 1,000 patient years from an epidemiologic standpoint. To put it more into numbers, you might understand a little bit better. 2 out of every 1,000 admissions in tertiary pediatric centers tend to be osteo or bone or joint related. There are some increases reported out there, but I say that they're pretty small increases that have occurred. There is some suggestion that younger patients may be at higher risk than other publications may say older, but there could be some age-related considerations. One thing that is a little bit more consistent, males are consistently more high or have higher occurrence of osteo or septic arthritis than females. And important in terms of the pathogenesis and pathophys that we just talked about, hematogenous is more commonly occurs in children versus adults. Adults tend to not have a hematogenous spread, whereas kids tend to have that hematogenous, where it's either you don't really have a source or it's bacteremia and osteo or septic arthritis. Now, in terms of diagnostic considerations, I'm going to go through it pretty quickly, just so that you understand what goes into calling someone or saying patient has osteomyelitis or septic arthritis. Typically, the symptoms they present with, some kind of pain. They may be able to say, hey, my bone hurts in this area or my knee hurts. But you may or may not actually see anything in that area. They may have fever, although not every patient has fever, but good bit do. And importantly, if they are nonverbal, you could have decreased mobility versus them being able to say that they have pain in a specific area, or a limp, or they can't crawl, or it hurts whenever they hold them. Whenever you hold them, they scream or something like that, suggesting pain in a specific area. Now, whenever some of those symptoms are present, people are then going to start getting labs. You're going to see inflammatory markers go up, increased white blood cells, C-reactive protein, and even erythrocyte sedimentation rate, or ESR in this case, which is a little bit unique, but definitely a sign of osteo. And typically these inflammatory markers are really high, not just barely outside of normal. Usually they're high, sometimes even above the limit of detectability in certain patients. And then once they have sort of those presenting symptoms and some of the labs that are suggestive of possible osteo, important thing for pharmacists to know is that an MRI or magnetic resonance imaging is the preferred diagnostic study typically for osteo. And importantly, why I make a big point here is that these patients are probably going to get IV contrast whenever they get this done, which means we as pharmacists need to be aware to monitor for nephrotoxicity, because some of the contrast could be associated with nephrotoxicity. In some cases, if there's a surgical procedure that needs to be done, bone biopsies may be considered to get down into the source. They may even cut away some bones in some scenarios, but that doesn't happen in all of them, but sometimes you do have bone biopsies that occur. Now, since this is an infectious disease, it's always important to talk about cultures. So in osteo or septic arthritis, you're typically going to get blood cultures, which even in hematogenous osteomyelitis, only 32% of the time is there definitely going to be a positive blood culture. And then other times you're going to get site cultures. So this could be tissue or abscess culture if there was some sort of surgical procedure done to get rid of an abscess or cut out some bone or something. And again, bone biopsy, sort of similar to the tissue, but directly on the bone to see if there's anything growing in there. And then if it's an arthritis, you're going to actually get it from the joint itself. They aspirate it and pull out fluid and are able to get cultures that way. Now, this is typically referring to site or traditional culture methods, meaning putting it in a culture media, seeing if things grow. And based off of these procedures, typically a site culture and a blood culture combined, you're going to get better yield than just a blood culture, just a site culture, with about 55% sensitivity for detecting an actual pathogen. Now, if you have fluid from the site, there are molecular PCR detection methods which may be able to be done and may be able to detect certain specific bacteria, and that could increase the positivity or the sensitivity of the test for detecting a pathogen. So big take home from this is 45% of the time you may not be able to detect a pathogen. So in the event that you are able to detect a pathogen, this slide has most of the common pathogens that you think about with osteo, and these are based off of those that are actually cultured, because again, you may not get a pathogen in each scenario. But from the community-acquired side, Staph aureus, 75 to 90% in the literature of the cultured pathogens are Staph aureus, with somewhere around 40% of the Staph aureus being methicillin resistant. There were some increases, between 2000 and 2004, and probably the peak of MRSA probably happened in 2008 to 10-ish, and we've kind of been going down a little bit since then, but usually we're still around 40% at most places nowadays. And it could also be methicillin susceptible. Now, I highlight Kingella here, which, if you're thinking Kingella, you're thinking less than 5 years of age. It's a possible pathogen. Highest somewhere between 6 months, 2 years, or 6 months to 4 years, maybe even less than 2 years. And this type of pathogen is likely more common in septic arthritis than osteomyelitis. And there are some recent studies showing that this could be a pathogen in up to 51% in certain countries. This data actually came out of Switzerland. And this got higher mainly due to the fact that this institution also started doing PCR-based testing to detect Kingella in a lot of these scenarios, because Kingella is really hard to culture via traditional culturing methods. And so in that study, they actually got almost 70 or 80% of their osteoarticular infections to have a pathogen, because they increased the amount of Kingella detected in those scenarios. So it's interesting that within the past 5 to 10 years or so, we've really started to be able to detect more Kingella, which has changed our thought on what sometimes is one of the more common pathogens, but most of the time we're still saying Staph aureus is going to be, your number one cause. Other possible causes, group A strep or strep pneumoniae, although that's a lot less common since the Prevnar vaccines have come out. Haemophilus influenza, if you go back, decades in the literature, you're going to see that, but it's a lot more uncommon now due to vaccines in most countries. In the neonates, you may see GBS or E. coli and Kleb species as possible pathogens, but outside of the neonatal period, they're not really that commonly pathogenic. Other specific situations, sickle cell disease is commonly associated with Salmonella, Osteo, or septic arthritis. If you're worried about some sort of contaminated soil or water-related injury, you have to add Pseudomonas in the mix. And if it's hospital-acquired or surgical-related, you also have more gram-negatives or potentially polymicrobial. If they're immunocompromised, you could have fungal, HIV associated with Bartonella, and potentially other common pathogens in immunosuppressed patients, but those are the unique ones. So these are usually pretty small proportion of your osteo or septic arthritis cases, but if you think specific disease states, you may consider adding, coverage for these because they can happen in certain patients. So now we've gone over what the bugs are. You should then design your empiric treatment options before, this is empiric before you know what the actual pathogen is, based on what the most likely pathogens are. So as we said before, most of the time we're covering gram-positive. We're targeting Staph aureus for osteo or septic arthritis. And then you may consider adding on gram-negative or other specific antibiotics for certain patients who you think may have risk for other types of infections. So typically, you're only really targeting gram-positive. You may add on some cephalosporins if you're worried about other pathogens in specific patients. A lot of times we may not know they have osteo, so these patients may be on cephalosporins in the first place, but if you're really only looking at osteo, most of the time we're going down Staph aureus route and kind of not worrying about the rest because it's not as high a proportion. Usually starting with IV therapy, although that could depend on the severity, but the overwhelming majority of the time, you're going to be starting IV therapy in these patients. And so a lot of this comes down to your local susceptibilities for Staph aureus, because empirically, you're going to cover for Staph aureus, so then you look at your local antibiogram and see, okay, what agents cover Staph aureus at our institution. And so if you look at the guidelines, they have this in like a table format, just to give you kind of a different format to look at it. I did it in a flow chart. But starting with Staph aureus, you're supposed to look at your Staph aureus methicillin susceptibility or methicillin resistance at your local institution. And so if your resistance to methicillin for Staph aureus is less than 10 to 20%, then you go with some kind of MSSA agent, which is typically cefazolin or nafcillin and or oxacillin, whichever one your institution uses. And you're kind of going down the MSSA route. If you have more than 10 to 20% methicillin resistance, then you can start looking at your clindamycin susceptibility, because clindamycin is a common drug we use. If your clindamycin resistance is over 10 to 20%, you're going to go down the vancomycin route. Maybe if they're stable, you may go back to the MSSA side, but most of the time people are going to put them on vancomycin. And then if they're moderate or severe, you're definitely going to do vancomycin, and some institutions may even consider other agents there. If clindamycin resistance is less than 10 to 20%, you're going to put them on clinda in most scenarios. So this is kind of the scenario or the flow chart that they outline in the guidelines. I put it in a little different format for you here. And then I'm also going to highlight some of the challenges and scenarios we come into whenever we try and design empiric therapy for these patients. So first of all, looking at your Staph aureus local resistance patterns, usually you're going based off of your institutional antibiogram versus osteo specifically. And so at some institutions, there may be differences between what your osteo or septic arthritis patients see and then what your whole institution antibiogram looks like. So sometimes you may have to delve into your antibiogram to figure out what your osteo and septic arthritis patients actually look like. And the whole less than 10 to 20% methicillin resistance, very few, if any, institutions are actually in this scenario. So most of the time you can probably ignore that as being able to go to that in all patients. There's another pathway to get there. If your clindamycin resistance is a little bit higher and the patient's reasonably not sick, you could try them on an MSSA agent, but most people are probably going to opt to go the other route. Then once you get down into the whole stable versus moderate to severe, differentiation, which could lead you down different paths. This can be really difficult to figure out, what is considered stable in one patient versus another. I typically say if they're not in the PICU, then they're reasonably stable, but there are lots of different definitions out there, and it leaves it up to a little bit of subjectivity here. And then we also have some bacteriostatic agents on here, which makes it interesting empirically. If your patient's sick enough, to say, okay, I'm going to try and start you on a static agent, which can be a difficult sell whenever you look at your sepsis guidelines, and they say in sepsis, you should start with a cidal agent. So, there's not a definite contraindication or anything there, but just sometimes you have difficulty saying, let's start with clindamycin whenever your patient has lots of sepsis criteria. So the end result of this is most patients are usually started on vancomycin at a lot of institutions, at least at some of the institutions I've been at. Other places may be using more daptomycin or ceftaroline. We typically still stick with vancomycin, but in the scenarios that I've shown you here, a lot of patients end up going to vancomycin or some other kind of cidal MRSA agent due to the scenarios I presented here. So that's why talking about vancomycin is very important for osteo and septic arthritis. And again, going back to the guidelines, there's more detail in there than what I have here. I just kind of hit the highlights. But it's, vancomycin is a bactericidal, although some will call it slowly cidal glycopeptide. It binds to the D-alanine part of the cell wall, inhibits glycopeptide cell wall synthesis generally, works as a cell wall type agent. There is some dosing here. I didn't put the preterm or infant dosing on here because that would take up a large portion of the page, but you can look it up if it is a preterm, baby, how to maybe best dose in those ages. But then whenever you get into the infants and young children, you're typically talking about 40 to 80 milligrams per kilo per day divided Q6 hours. A bit of controversy on that. The osteo guidelines actually say 40 to 60 milligrams per kilo per day. The vancomycin guidelines say 60 to 80 milligrams per kilo per day divided Q6. Some also may do a Q8, FYI. But, if you follow some of the literature on attaining appropriate concentrations, most places are going towards 60 milligrams per kilo per day as their starting dose, although some institutions may go higher if the patient is sicker. And then whenever they get older, there is a thought that these patients may not be able to tolerate as much due to renal function changes. So typically your starting dose over 12 years of age is 60 to 70 milligrams per kilo per day divided Q6 to Q8 hours. And again, the osteomyelitis guidelines don't differentiate in this category, but that's what's in the vancomycin guidelines that were published. And in the past, we used to push doses a lot higher, but the newer guidelines suggest don't go over 100 milligrams per kilo per day, and also be careful over 3 grams per day. So those are some reference sort of maximums, although there is some debate as to if the patient can tolerate it and they need it. Some Institutions may still go higher than that, but that's what's in the vancomycin guidelines. You're typically not doing a loading dose except in obesity. It hasn't been shown to be quite as effective in kids. Again, not to say that some institutions may not do it, but typically per the guidelines, that's not recommended. And always remember that kids are going to be, we're going to be giving them more frequently compared to adults because they have a shorter half-life for vancomycin. Some major side effects during the infusion, they can have the vancomycin infusion syndrome, which is a redness that starts in the face or neck area, typically occurring during the infusion. Importantly, it's not a 100% true allergy. Typically can slow the infusion, typically an hour and a half or 2 hours. And then you could consider pre-medicating with diphenhydramine. Typically takes care of it. And then the other one that we're really worried about is nephrotoxicity. There's some decent literature out there that it's an independent association with nephrotoxicity, although it has historically been debated as to its independence away from other factors. But we do know for sure that it's even higher with concomitant nephrotoxins, like the contrast we talked about with the MRI or other nephrotoxic scenarios like shock or pressors. There's also trough concentrations greater than 15, AUC greater than 800 as possible predictors of AKI or putting them more at risk. And importantly for osteo patients, these patients come with bone pain. They've usually had NSAID therapy on as an outpatient, and then they may get put on IV ketorolac or something as an inpatient, probably got an MRI with contrast, and there's a good chance they're dehydrated. So osteo patients within the first few days of admission are pretty high risk for AKI due to vancomycin. So it's important as pharmacists to know this and make sure that we're monitoring them appropriately. There is some, historical concerns for ototoxicity. It's not 100% proven, in my opinion, but people will still be concerned about it and consider hearing tests with really high concentrations. If you've had patients that have concentrations 50, 60, 70, 80, 90, then maybe consider doing hearing tests in those patients, but we're typically not super worried about that. In terms of monitoring, it's always important to know that if a patient's renal function changes, that's going to change your vancomycin because it is highly renally eliminated. The guidelines suggest area under the curve monitoring with a goal of 400 to 600, potentially using Bayesian programs. And again, they suggest more toxicity with greater than 15. So why we're typically not targeting those high concentrations of 15 to 20 that we used to a few years ago. There is some controversy with the new guidelines as they came out. Most of the AUC MIC data for 400 comes more from the adult population. And there's a thought that, are we achieving that with a lot of our dosing in pediatric patients? And is it as big of a concern? We're not really sure. And there is some questions out there as to whether or not Bayesian programs are appropriate for use in children. And so then if you're not using a Bayesian program, do you have enough blood or enough opportunity to actually get to concentrations and do first order kinetics? And important here, practice may vary, but my suggestion is always to look at the patient's response. We have concentrations that we can target, but look at if the patient's getting better or worse, and also make sure to include that in your decision. But at minimum, most places are at least getting troughs and or AUCs, and you should be aware that you should do some kind of monitoring if they're on vancomycin for a reasonably long period, more than 2 to 3 days in patients with osteo or septic arthritis. Another drug I'm going to talk about, which were in the empiric recommendations, is cefazolin. This will be considered potentially first line for MSSA. First generation cephalosporin binds to penicillin binding proteins, and again, inhibits cell wall synthesis. Again, preterm neonates or infants, dosing is going to be a little bit different, but in infants and children, somewhere around 100 to 150 milligrams per kilo per day, typically divided every 8 hours, with a max there. Usually there aren't too many crazy side effects with cefazolin, but there can be some allergic reactions in some patients. There's a small chance possible of cross-reactivity with penicillin allergies, but it's usually pretty small. Some clinical pearls. This may be preferred over to nafcillin or oxacillin due to less side effects, typically infusion-related side effects. But on the flip side, it also could be considered slightly more broad spectrum than for MSSA. However, from the stewardship standpoint, they're a bigger fish to fry usually than cefazolin. And just another pearl to know, we talk about methicillin susceptibility and methicillin resistance, but just know that cefazolin, if it is methicillin susceptible, we are inferring that it is cefazolin susceptible also, even though it's not listed on the report. And also remember that methicillin is not the actual drug that's tested for the Staph aureus susceptibility. It's usually either oxacillin or actually cefoxitin may sometimes be used. But if you see MSSA, even though you don't see cefazolin, you know that you can typically use cefazolin. It's a surrogate for all other agents that are considered susceptible for MSSA. I've already talked a little bit about it, but nafcillin and oxacillin are also considered first-line agents for MSSA. This is an anti-staphylococcal penicillins. That again, cell wall synthesis inhibition or prevention of cell wall synthesis. 100 to 200 milligrams per kilo per day divided Q6 is the typical dose in infants and children. May be less frequent in lower doses in neonates and preterm infants. Now there is a little bit higher chance of adverse reactions here with allergic reactions. It's also potentially a vesicant and can cause a lot of irritation and skin damage, potentially losing peripheral lines. I've heard many a physician say, I just can't lose any more peripheral lines using nafcillin and oxacillin. There is a possible AKI association with it, and there are some reports of neurotoxicity with higher doses, although it's kind of hard to always assess that. Pearls, again, most labs use oxacillin or cefoxitin, and generally there is no real difference between oxacillin and nafcillin. So whatever your institution has on formulary may be the one that you're using there. Another possible first-line agent that may target MRSA, also technically could target MSSA too, is clindamycin, which is a lincosamide, bacteriostatic inhibition of protein synthesis. So the other ones we've talked about so far have mainly been cidal. Clindamycin is generally considered static, especially against Staph aureus, and it is a protein synthesis inhibitor by binding to 23S RNA of the 50S ribosomal subunit. Some other unique things, it's believed to have an antitoxin effect against gram-positive agents, which could be beneficial if these patients have a toxin-producing strain. And you also may sometimes add it on to a cell wall agent, one of the ones that we talked about in the last couple slides, to prevent the eagle effect, which is exhibited against cell wall agents. This is largely conceptual though, but sometimes you may hear about that as a reason to be using clindamycin. Dosages typically for Staph aureus, you're talking 30 to 40 milligrams per kilo per day. You'll see divided Q6 to Q8. Most people will probably do it Q8 hours. In terms of side effects, diarrhea is certainly a concern. C. diff, very high rates in adults. It's a little bit less in children, but certainly something to still be worried about. And from the IV side, you will hear patients complain of metallic taste while they're receiving the medication. And again, because it's bacteriostatic, there's some controversy as to can you really give it as an empiric agent whenever you haven't really ruled out bacteremia or really severe disease up front. So that's why sometimes clinicians may be reluctant to just put them on only clindamycin at the beginning. All right, so those are some of our big hitters on the empiric treatment options side. Now, whenever you get to definitive, remember, there's often a lack of a positive culture. So typically you're going back to empiric and saying, okay, I'm going to cover for Staph aureus and hope that what I picked ends up being good and go based off of response. If the cultures are available, ideally we try and get them to a first-gen cephalosporin or clindamycin for most Staph aureus strains. For strep or other species, we may be able to narrow them even further to aminopenicillin or something like that. And there's always the goal of eventually getting them to an oral option when able and based on the response of the patient. This gets a little bit more controversial if it's MRSA, definitely with clindamycin resistance, because your options get a little bit smaller, which we'll get to in a few minutes. So the transition to PO, when I learned this as a student, I learned osteomyelitis. You always teach IV, or you always treat IV, but a good bit of studies started coming out to say, hey, we could probably transition to PO for most patients with osteomyelitis. This slide shows you some of the studies that were large database studies that showed, patients who were put on oral antibiotics versus IV antibiotics at discharge. And typically these tried to target uncomplicated cases. But the take-homes here, these are lots of patients done by big database studies that don't always have all the details of the patient, but can get you large sample size. So we're talking 2,000 children. That's a pretty good sample size. And they started showing that failure rates seem to be the same with IV and PO. And then what was more concerning is that patients who were sent home on IV with PICC lines actually had more complications because they had to be readmitted for PICC line related issues. So there's a thought that you probably have equal efficacy PO and IV, and that you remove the chance of possible PICC line issues if you switch them to PO. So these studies started showing, okay, maybe we should be trying to get patients to PO if they're not super complicated for osteo and septic arthritis. And so then there were a slew of sort of institutional studies that showed how they kind of picked their patients. And I'm not going to go through all of these, but here are the ones for your references. And the general gist is there weren't many failures or issues or more than expected, and their protocols seemed to work. And the common themes down here at the bottom, and kind of my take home from a lot of this stuff, is you're watching for improvement in the patient over a few days. You want to see their CRP ESR go down. Hopefully fever is improving or completely afebrile and they don't have a positive culture. And when I mean positive culture, I mean blood culture, and there's also no chance of having another surgical procedure due to their osteo. So what this ends up being is that around 2 days of IV antibiotics, people can then start asking, okay, I have, either a culture that is negative or I have a repeat culture that's pending. This is blood cultures, to see if there's an actual bacteremia still present. So that's where the 2 days comes from. And then you might be able to start repeating labs to see, okay, have things went down. So again, fever going down, CRP going down. Some people have shown a CRP decrease of about 50% or more as being a surrogate for, okay, let's switch them to PO. But things have to be improving. They don't have to be back to normal. Nothing has to be completely normal. But things should be improving. And also on here, symptoms are typically starting to resolve. If the patient couldn't walk, maybe they're starting to be able to be more mobile before you start switching. Now, importantly, the complicated cases, going back to your complicated versus uncomplicated, are not as well studied. So a lot of this applies more to your uncomplicated. So we talked about cefazolin, the first generation cephalosporin that's IV. Cephalexin is typically our oral transition for that. So first generation ceph dosing is a little bit similar, but probably a little bit lower in osteomyelitis, somewhere around 75 to 100 milligrams per kilo per day divided Q6 to Q8. Some people may go up to 150, but typically 75 to 100 is where you're targeting. Can be some GI upset with any oral antibiotic, and also can have some hypersensitivity reactions. There are some reports of absorption issues in infants and neonates, but typically we're still able to use them in these patients. So, this is typically a go-to drug for MSSA in osteo and septic arthritis. Clindamycin, we talked about IV, also an oral option, same mechanism of action. Whenever you do about similar dosing, but you may not give as high of a single dose at times. Some reports will say 600, maybe sort of your max PO dose because of toleration, mainly because you have a lot more GI upset with higher doses. From the pediatric side, it comes as a reconstituted solution or a capsule. The solution is notorious for being pretty bad tasting. There have been some recent manufacturing changes that made it a little bit better tasting, but still not the best. So a lot of times we try and get a patient to a capsule so that you maybe could sprinkle it over some food or something, even if they can't swallow it. But other times you may be stuck with a solution, but you do have to make sure that they can take it and are able to keep taking it when they get home to make sure that compliance isn't an issue. And again, same side effects with clindamycin orally as PO, maybe a little bit more GI issues. Now, linezolid, typically I would call this a second-line agent, and this certainly depends on susceptibilities. It is an oxazolidinone, which has bacteriostatic inhibition of protein synthesis, somewhat similar to clindamycin, but a little bit different. And it is cidal against some pathogens, but not necessarily against Staph aureus, so we typically are considering it static, which we talked about some issues with possible static drugs. Empirically, it is believed to have the toxin effect similar to clindamycin and could potentially help with the Eagle effect also. Doses are provided here, depending on age, 20 to 30 milligrams per kilo per day. And you may give it a little bit more frequently in the younger children. Now, one thing to highlight about linezolid, it is listed as a reasonable option in the guidelines, but it does have some pretty significant side effects that are somewhat worrisome, and a lot of them are duration dependent, usually more than 2 to 3 weeks, and in osteo we typically are treating for more than 2 to 3 weeks. This includes neutropenia, thrombocytopenia, and some potentially severe visual field changes and neuropathies that, can take quite a long time to go away, and maybe in some reports of them not going away. And so some reasonably severe issues there, and especially in kids, if you don't have a kid that you can actually test their visual field, then you may be worried that you're not detecting the toxicity of linezolid in the younger kids. There's also a lot of drug interactions with MAOI inhibitors and serotonergic agents. And so, in my opinion, linezolid, we sometimes have to go to it. There's no other route, but it's not always the best drug for osteo or septic arthritis due to the longer durations. Sometimes we may try and minimize its duration to prevent these side effects, but it's out there, but there are some toxicities with it. Now, trimethoprim sulfamethoxazole, or Bactrim or Septra is another brand name for it. Typically considered second, maybe third line. It's sort of listed in the guidelines, but not really. They said they can't really make a definite recommendation on being able to use it, although there are some studies and case reports that have used it for osteo and septic arthritis. Mechanism of action, 2 different drugs, one that impact the folic acid pathway and folic acid synthesis within the cell, so definitely different mechanism than most of your other drugs. Dosing can be pretty wide, somewhat anywhere between 8 and 20 milligrams per kilogram per day of the trimethoprim component, typically divided 2 to 3 times. You'll usually hear somewhere between 8 and 12 is a typical dosing range, but just know that up to 20 milligrams per kilo per day has been reported. There are some concerns about using it in infants due to bilirubin displacement, and again, nothing definite in the osteo guidelines. And they did that because, or the author said they didn't make a recommendation because there weren't any prospective trials assessing it, although lots of retrospective have been done. And from the IV side, it has a lot of fluid whenever you administer it, so it's not really ideal from the IV side either. It does also have some side effects. One of the most common causes of Stevens-Johnson syndrome or toxic the TEN. You also can have some toleration issues, hypersensitivity reactions. There are some alterations in serum creatinine, although they typically go back to normal, and some photosensitivity and rashes in the summertime. Can have some anemia and neutropenia, likely duration dependent. And the guidelines also suggest that there are some conceptual concerns with its impact on folic acid synthesis and bone turnover. Some people may use it in combination with rifampin also, just to make sure that they're getting some activity. And again, some controversial concerns when used for bacteremia or severe sepsis. So really, this is more of a definite step-down agent option if you don't have many other options left. So I've alluded to this before, but in terms of treatment duration, guidelines do make a reasonable statement that say that they're favoring 3 to 4 weeks for most uncomplicated cases. Anything greater than 4 weeks is considered long-term and not typically favored in the guidelines. But there is some controversy when it gets to MRSA and complicated cases. So typically, what we see is a patient gets stabilized, they get sent home on PO, and then there's a schedule up ID visit at about 3 or 4 weeks. They make a judgment call as to whether or not to continue or not, because by that 3 to 4 weeks, they should be completely resolved of all of their issues. One other thing to note is septic arthritis typically is can be easier to treat at times if it's, an uncomplicated septic arthritis, and are more likely to be around that 3-week duration. Now, that's if everything goes well. Now, as pharmacists, we're typically going to get consulted whenever things don't go well and they have to go outside of the guidelines. So what happens if the patient is not initially responding to therapy? We've all probably seen this where we have them on a drug that should be working, but things don't seem to be getting better. And so here's an attempt at a definition of this. They start antibiotics, haven't had significant improvements in fever, pain, mobility, and they have, 3 to 7 days of positive blood cultures. Always ask yourself, is there a source control issue? Do they need to have another surgery? Is there another infection that we're missing at a different site? Optimize your dosing, increase your doses as much as you can safely to try and improve outcomes. And then if you've done all those and you've checked all those boxes, the other possible decisions are, you could add on different coverage. So if the patient's less than 5, you might add on something with Kingella coverage, which is typically a cephalosporin or an aminopenicillin plus or minus, beta-lactamase inhibitor. Or you may either add on other gram-negative coverage if you think they have specific risk factors for it. We already talked about maximizing the doses. And then there's also a possibility you could add on or change to different agents based on susceptibilities. So that's where you get into these sort of second and third line agents. I have daptomycin as a second, but you could also call it a third line at times for MRSA. So daptomycin has an interesting mechanism of action. It binds to and depolarizes cell membrane and inhibits intracellular DNA, RNA, and protein synthesis. Very bactericidal and concentration dependent. Really a good drug against MRSA. But typically we try and reserve it for the patients that really need it so we don't get resistance to it eventually. Dosing is provided here. You give a little bit higher dosing in the younger kids because you want to get that peak concentration. Advantage of it is it's only once a day dosing. So if you have to send someone home on IV, some people may prefer it because it's Q24. Although again, we try and reserve it for patients who definitely need it and have sort of failed other treatments. Some pearls, the main side effect, rhabdo, is of concern, and patients may also have muscle pain. So you may monitor creatinine kinase. You can't use it if they also have a pneumonia. And there's not a lot of great prospective randomized studies saying that it could be used. So that's why a lot of times it's used a little later on. But again, not saying that some institutions may not use it more upfront. Ceftaroline, also typically second or third line for MRSA. This is a cephalosporin, but it does bind more specifically to penicillin binding proteins 1 to 3, with Staph aureus activity mainly being due to the PBP2A affinity of the drug. Dosing here, 45 milligrams per kilo per day divided Q8 is the most common dose recommended. Side effects, some positive Coombs tests, agranulocytosis, C. diff is possible. The biggest concern with this is that we have a lot of gram-negative coverage that we a lot of times don't need. So sometimes if you have a gram-negative and a gram-positive, this could be a good one-drug regimen. But it's if you're just targeting Staph aureus, where you got a little bit extra there. And it's also not super well studied in osteo. Now, other add-on agents you could consider, some of these are listed in the guidelines. Gentamicin could be added for synergy. Rifampin could be given IV or PO, especially if they have some sort of hardware, and some people recommend adding it on to the Bactrim whenever it's used. It does have good bone penetration and activity against biofilm, but always watch your CYP interactions. As I said before, some people may add Clinda and or occasionally linezolid to a cell wall agent due to the Eagle effect. And in the adult world, there is some literature saying maybe people should add a non-MRSA beta-lactam to an MRSA agent to help with clearance. That is a bit conflicting in the adult world, and there's not much in the peds world. And typically, a lot of times, our patients are on both of them anyways. So there's, we personally don't use this very much, but that's not to say that other people may not try it. In some scenarios. Now, I've talked a lot about Staph aureus. Here's some information on some of the other possible pathogens. Strep, we may be able to even narrow more than targeting gram-positive agents to some sort of aminopenicillin. Kingella, typically you need some sort of cephalosporin. Pseudomonas is going to require either an IV cephalosporin or PO-fluoroquinolone. H-flu, also maybe a cephalosporin, and Klebsiella is going to vary based on its susceptibilities. But these would be in those patients who have these types of infections. Now, there is a such thing as chronic osteomyelitis, which we said before. There's not much concrete evidence. It usually involves giving longer courses of antibiotics, maybe giving having multiple surgeries, and maybe giving multiple types of antibiotics for these patients. Just beware anytime whenever someone puts surgical paste into a patient. There is systemic absorption from those, and I have seen toxicity from that. So the chronic osteo kids get really complicated. There's not much evidence out there. A lot of times as a pharmacist, you're just trying to use rational decisions and try and manage any possible toxicities when possible. Now, one other concept you should be aware of is that bone penetration always comes up as to, okay, which drug gets me the best concentrations there? Conceptually, this should be super relevant, but there's not really many studies showing that, low bone penetration definitely goes to poor outcomes. For example, we've talked a lot about using first-generation cephalosporins, but their bone penetration is sometimes listed as 6 to 7%. Whenever you compare concentrations in bone to blood. Penicillins are a little bit higher, but one of the reasons clindamycin is highly favored is because it does get pretty good bone concentration, 65 to 70%. Linezolid's also pretty good, close to 50%. Vancomycin is pretty variable. Trimethoprim sulfamethoxazole or daptomycin are considered well above MIC 90, and I don't have it on here, but rifampin is also considered well above its MIC 90 for staph in the bone. So I put it here just because it often comes up, but just know that we have seen success using agents with poor bone penetration for osteomyelitis. don't have a great reason why, but here's some bone penetration data in case you ever need it. So some key concepts to highlight: osteomyelitis is commonly hematogenous in children. Septic arthritis, also commonly sometimes believed to be that hematogenous. And that's why the osteo guidelines are called acute hematogenous osteomyelitis. Medication therapy targets mainly gram-positive pathogens, except whenever you think your patient is in a scenario where they may have some sort of gram-negative or a different pathogen. Vancomycin, commonly used agents, cefazolin and cephalexin are also in there. Oral therapy is now widely more accepted for most osteo cases, and septic arthritis for that matter. There are lots of second line options. Most of the time, whenever you have second line options, you're targeting some sort of bad MRSA infection that's not responding to therapy. And us as pharmacists, that's when we're going to start getting a lot of those questions. So make sure you at least sort of know what the possible options are if someone wants to try and use them. Here are some references, alphabetical for your reference that I use throughout the talk. And for audience questions, I'll pause in between each of those, but make sure to pause from your side so you can think about the answers. So question 1, among pediatric osteomyelitis cases, which of the following types is likely to make up the largest portion of pediatric cases seen? So which of these scenarios is the most common that we're going to see? So I'll give it a few seconds, but make sure to pause if you're viewing the video. Okay, so remember, kids, hematogenous, most common cause, and then we're talking about long bones. So foot metatarsal, we do occasionally see them, but the tibia is going to be more common than that. Forearm cellulitis, we don't see as much contiguous spread, so that's probably going to be less likely that a contiguous cellulitis spreads down through the forearm. And diabetic foot infection, definitely more common in adults than in kids. All right, question 2. 7-year-old admitted to a general pediatric unit for likely osteo and is clinically stable, lacking concerns for severe sepsis. Among osteomyelitis and septic arthritis at your hospital, you see 60% MSSA with clindamycin covering 92% of Staph aureus. Which of the following is a first-line recommended empiric treatment option at your institution per the 2021 guidelines and is also available orally for the treatment of osteo? So take a few seconds again to think about that. All right, so I was trying to point you down the route of clindamycin, although again, some places may use vancomycin in this scenario, but this patient has no concerns for severe sepsis on the pediatric unit. So if your institution has less than that 10 to 20% of clindamycin, per the guidelines, you could use clindamycin in this patient because it covers 92% of your Staph aureus. Linezolid technically is an option, but again, that's more of a second-line option, not the preferred option. And I labeled it as first and second, but in the guidelines, they may call it preferred. Daptomycin also, sort of a secondary agent. And this really becomes vancomycin versus clinda, but the guidelines do give the possibility of using clinda in this type of scenario. And for our next patient, or our next question, a patient is started on vancomycin and is being worked up for possible osteomyelitis. Which of the following diagnostic procedures could impact the safety profile of vancomycin in this patient? So pause and take a few seconds. All right, so I think I had highlighted this prior in the presentation, but MRI with contrast is a common diagnostic procedure for osteo and sometimes septic arthritis also. And so these patients are at risk for AKI due to vancomycin and concomitant contrast. And for our fourth question, an 8-year-old is admitted with a MSSA osteo. They had a fever up to 39.5 Celsius, a CRP of 85, and a positive blood culture on admission. On day 4, whenever you are pre-rounding, which of the following changes in the presenting symptoms would best suggest the patient may be able to change to PO? Pause and take a few seconds to look at this one. All right, so again, you want to see temperature coming down. So this patient's temperature went down to normal. And answer A, CRP went well more than half of a decrease, so almost close to a third or a quarter of the CRP that it was at the beginning, and its blood culture from day 2 was no growth to date times 48. So the repeating MRI, that's not probably the biggest thing, especially if there's still a little bit of an abscess left. The other two, the patients still had fevers and their CRP wasn't really improving, so you need to look at a constellation of things to see when a patient could be changed to PO. And our last question, 17-kilogram child being prescribed PO Keflex at hospital discharge for MSSA osteo, uncomplicated, that had a bacteremia but responded pretty quickly. Patient received 7 days. Which of the following is the best dosage and duration to recommend for this patient with a follow-up scheduled after completion to assess the need for continuation? All right, so the best answer here, we're looking at 3 to 4 weeks, so the 7 days are automatically removed. And then the dosing, this patient is 17 kilograms, so the 500 gets you closer to that, 100 per kilo per day, 75 to 100 per kilo per day of Keflex in this patient. The 250 would have been too small of a dose. All right, well, please feel free to email me if you have any questions, and I hope you enjoyed this presentation. Thank you.